Yes, multiple myeloma has advanced markedly in the 50 years that I have been in the field. When I started, there was no treatment available for multiple myeloma except a drug called urethane. Urethane was given orally, and the patient oftentimes had side effects from it. The drug was based upon experience with 2 patients who were treated in Sweden. One of the 2 had a reduction in monoclonal, or in protein and in plasma cells in the bone marrow, and the other did not. And so for 15 years, this and stilbamidine, which was very toxic, were the only drugs available for the disease. Then in 1966, the Eastern Solid Tumor Group did a prospective study comparing urethane with a placebo. And in this study, the placebo was cola syrup. And if one looked at the survival curves, the survival curve of the patients who received the cola syrup was actually a little better than the curve with urethane. And I can assure you that the patients who were on the placebo did not complain of nausea, of vomiting, or diarrhea, and they had no lowering of your white count or platelets, all of which were side effects of urethane. So in one fell swoop, urethane was dropped from the treatment regimens for myeloma. Fortunately, in 1958, the Russian physician Blokin reported a drug that he called L-sarcolysin. Today we recognize it as melphalan or Alkeran. And that was the first drug for the treatment of multiple myeloma that was truly beneficial for patients. Then in the next 3.5 decades, various investigators developed different combinations of alkylating agents. Your regimen was better than mine, his regimen was better than yours, and there was a lot of controversy as to which was best. Then, in the late 90s, the Oxford myeloma trialists did a very large multi-analysis looking at prospective randomized studies, those that use just melphalan and prednisone versus those that used any variety of combinations of alkylating agents. And I'm sorry to say that there was a modest improvement in response, but no difference in survival, whether the patient received melphalan and prednisone or any combination of alkylating agents. Then the next step was the introduction of autologous stem cell transplantation. As you probably know, the first case was reported by Tim McElwain from the Royal Marsden Hospital near London. And he did a transplant on a patient with plasma cell leukemia that was successful. And then other physicians, including Dr. McElwain, used it for myeloma. It was fairly toxic with a mortality of 10% or more.
When was it?
This would be during the 90s.
The beginning of the 90s?
Yes, yes. It was the beginning.
Okay.
McElwain had introduced stem cell transplant in the early 1980s, but it was throughout the 80s that it was developed and actually was not commonly done for patients with myeloma until well into the 90s. And then in 2000 came the first of the novel agents, and the first was thalidomide. And that was quite remarkable in that thalidomide had been used particularly in Germany and in other countries in Europe in the late 50s for nausea and vomiting of pregnancy, and produced a condition called phocomelia with the absence of the arms.
Some kids like this.
Yes, there are patients with phocomelia around today. And so it was started with a great deal of concern, but the STEPS program has been very carefully adhered to, and to my knowledge, there have been no cases of problems of phocomelia in any patient who was given thalidomide. The next major drug was bortezomib, or Velcade, and that drug is very effective, particularly in patients who present with kidney failure. The two shortcomings of bortezomib are the fact that it produces peripheral neuropathy, and the peripheral neuropathy will occur in almost all patients who receive the drug if they receive the drug for a long enough period of time.
Which means how long is
It is extremely variable as to the duration of time, and I think that one of the reasons for this is that many people, in fact, it has been shown in the neurologic literature that about 25% of people who are above the age of 70 years have a subclinical peripheral neuropathy. That is, if you examine the patient, or if a neurologist examines the patient, the examination is completely normal. But if one does electrophysiologic studies, one will find evidence of subclinical peripheral neuropathy. And I think that those patients who have, just because of their normal aging, have a subclinical neuropathy, they're the first to develop peripheral neuropathy. And there have been some patients who have had only a very few injections who have developed peripheral neuropathy. And of course, on the other end of the scale are patients who have taken it for several cycles and have not developed peripheral neuropathy. Today, one of the newest things with bortezomib is that it appears that weekly administration of the drug instead of the initial twice-weekly regimen is clinically effective. And I think now that most physicians are using the bortezomib or Velcade on weekly intervals. Now, the third new drug was Revlimid, lenalidomide, and that has two major advantages over thalidomide. It's an analog, of course, as you know, of thalidomide, and it does not cause neuropathy, or at least a minimal. I've had patients who have said, well, my numbness, my tingling is worse when I take the Revlimid, and that may well be true, but in general, we consider it to be a non-neuropathic drug. The second point is that it is given orally, and that's an advantage for the patient. Now, There is a new analog of lenalidomide that is called pomalidomide. That is not yet approved for use in any country in the world. We have had the opportunity of treating over 150 patients with that drug, and the very encouraging thing we find is that about 1/3 of patients who are already refractory to lenalidomide or to bortezomib will respond to pomalidomide.
You give me another hope. You give me another hope.
Yes, yes, it is another hope, and it is also taken orally. It's well tolerated. It can lower the blood counts, the white count, and the platelets, but it's generally very well tolerated. Another drug that we are working on is carfilzomib, and there is now a new large international study on carfilzomib, which is a proteasome inhibitor, like the Velcade, but it does not appear to cause neuropathy. I understand that the pharmaceutical company who is developing this has also an oral preparation of the drug, but they're going forward with the intravenous drug now, and they would want to get that approved before they get working seriously on the oral drug. So that sounds very encouraging for the future as well.
You gave me a lot of good time now, because you just told me how to talk to my fellows who suffer now for starting now, and I will be more than happy to tell them that we might look forward for another 2 other weapons to the arsenals of the doctors for us.
Yes.
Really encouraging.
It is really an encouraging time in the treatment of myeloma, because for many years we made virtually no progress. Yes, you're the beneficiary of many new things.
I am happy to say that I was born in such a period. I mean, my myeloma started with me in a good year.
Yes, yes.
I'm not sure that I could earn for or survive so many years if I started it earlier.
That's right. Although there are some patients who did extraordinarily well with the alkylating agents, and the woman that I mentioned to you initially that I first saw in 1979 received a combination of alkylating agents and obviously had a good response. And there are patients, I reported a patient some years ago who had a cure of his multiple myeloma from only melphalan and prednisone. This man went 21 years, at which time he developed a cough and coughed up blood and was found to have a cancer of the lung. He had been a smoker in years past, and he, as you might expect, died, and after his death we did an autopsy examination and could find no evidence of multiple myeloma any place in his body. We, of course, had looked at his serum and urine with immunofixation many times, always negative. All of the bone marrows we did were negative, and then at autopsy he had no evidence of disease. But I want to emphasize that this was an exceptional patient, and
end of the workouts.
Yeah, he's way out at the end of the curve. Yes, he's way out, and there are very few like him. But as far as the individual patient is concerned, I would emphasize to each of you that one does not know how one will respond, and one patient may get a perfect response that lasts for a very, very long time, and the next patient may get a much more limited response of their disease.
But still there is a hope.
There is always hope. There is always hope, and it's very important for the patient with multiple myeloma to continue with their life and their work and to keep on going. It's extremely important to get up each morning, put your feet on the floor, get up and go.
It's another day.
Do something like Matty here is doing.
Thank you. Okay. What do you expect for the next decade? We are getting closer to the cure of multiple myeloma?
Yes, I am sure that we are getting closer to the cure. I think that genetics, genomics are going to prove very important, and I think that we will be coming to the point that we will be able to predict which patients will or will not respond to a particular drug, and it will be important to be able to know that, because then one would treat the patient only with the appropriate drugs, because today we don't know whether you will respond to lenalidomide, to bortezomib, to thalidomide, to all three, or in some instances to none of them. That plus the fact that we have, as I mentioned a few minutes ago, new drugs that are coming, and I think the future is very bright for this very challenging and very serious disease. Well, first of all, I would encourage all patients to enter a clinical trial. In the United States, we have a major problem. Fewer than 5% of all patients with multiple myeloma enter clinical trials, in contrast to France, where 75 to 80% of patients with multiple myeloma will enter a clinical trial. I think that this is due to several things. In France, for example, all of the myeloma physicians and all of the myeloma drugs that are available for the individual are in university or in institute systems, so that when a patient is diagnosed with multiple myeloma, he or she will go to a hospital that is affiliated with the French myeloma group. This hospital may be near their home, but it is connected with a university center who does use the protocol, the same treatment, and that's the way that things get done. Also, the drugs are not available in general. If a person in France were to go to a hematologist or oncologist, the drugs would not be available for use. And secondly, there are very few hematologists or oncologists. In fact, I don't know that there are any in all of France who are in what we call private practice. In contrast, in the United States, we have many hematologists and oncologists who are in private practice, or more commonly practice in small groups in medical clinics or hospitals. And even though they many of them will have a loose affiliation with one of our cooperative groups, such as ECOG or CALGB or SWOG. The hematologist-oncologist is very busy, and it takes time to put patients on study, and these patients don't go on study. Furthermore, many patients in our country are very knowledgeable about their disease. Thanks to the internet, to the International Myeloma Foundation and the like, they become very knowledgeable about their diseases, or about their disease myeloma, and they, being intelligent, informed patients, make up their own minds by and large is that I will have a transplant or I will not have a transplant. I want to have Velcade or I want to have Revlimid or what have you. And so it's a major problem in getting patients in the United States on prospective randomized studies. Now, you asked one other point about maintenance therapy. This is a very controversial point at the moment. There have been several studies that have reported that progression-free survival, that is, the patient is continuing to live, is alive, and has no evidence of progression of disease. And our FDA, which approves drugs, accepts the progression-free survival as a viable endpoint, and that is fortunate in that it allows us to make conclusions or evaluate the data earlier than if we relied on overall survival. However, I would emphasize that overall survival is the most important parameter for measuring efficacy of a drug. But we can't wait for that for all instances. Now, just to make things more complicated, for example, there have been 4 or 5 very good studies comparing melphalan, prednisone, and thalidomide versus melphalan and prednisone. And in all studies, the melphalan, prednisone, thalidomide has a longer progression-free survival. Everyone agrees about that. But 2 or 3 of these studies only showed an overall survival benefit. And so, in my mind, we don't really know. And now, I think that if one has a study looking at progression-free survival, for example, there have been a couple of studies reported of patients who have received an autologous stem cell transplant, and then they have been randomized to lenalidomide or Revlimid maintenance or to no maintenance. And of course, it's not a surprise to learn that the progression-free survival is longer in the patients who were randomized to the Revlimid, the lenalidomide maintenance. However, I am not convinced that if those patients who were randomized to placebo at the time that they relapse, if they were given lenalidomide at that time when their disease came back, I suspect, I have no proof, but I suspect the overall survival is going to be the same. Now, many physicians say, oh, but you should put the patient now on maintenance because it is proven. Well, it is proven for progression-free survival. But keeping a patient on maintenance has potential problems. First of all, the patient is on a drug, and the patient must have blood counts at regular intervals. Because one may get into trouble with neutropenia causing infection or thrombocytopenia causing bleeding. So that's a problem for the patient on maintenance therapy. Secondly, that clone of tumor cells is rarely destroyed by the transplant and the maintenance Revlimid. And exposing that small tumor mass, that small clone, to Revlimid over a long period of time may result in resistant disease. And as you know, if you treat a patient with melphalan for a long period of time, that patient by and large becomes resistant to the disease. Thirdly, there is no such thing as a safe drug. And I don't know, but it's certainly possible that some serious side effect could develop in patients who have received Revlimid or any other drug for a long period of time. I would point out in my experience that we used melphalan and prednisone for 10 years, for an entire decade, before we recognized that it could cause myelodysplasia or acute leukemia. And when we reported the first 4 cases of myelodysplasia, many physicians in the United States and in Europe did not accept that. They said, that's not right. That would have occurred anyway. Now we know that there are specific chromosomal abnormalities associated with myelodysplasia or acute leukemia, and everyone knows that alkylating agents can be harmful. And then last but not least, lenalidomide is an extremely expensive drug. And should we be using it for maintenance, or should we be using it for the patient to be treated initially? Our cost of medical care in the United States is very, very high, and these expensive drugs are making it higher, and it's something that I don't think will be sustainable in the future. I think that Israel, Western Europe, is facing the same sorts of problems for the future. And for those reasons, I personally think that it is better to treat the patient with the autologous stem cell transplant if the patient gets a good response, a very good partial response, or a complete response, to stop and to follow that patient, and then to treat that patient when the disease reoccurs. That's an opinion. There's no solid data to support that, but that's the way I feel.
Yes.
I was just telling Mitty that some patients do extraordinarily well. I have a patient that is living today that I saw in 1979 and treated her on a CALGB protocol utilizing a combination of alkylating agents, one of which was intravenous melphalan. The patient at the time of diagnosis had true multiple myeloma with lytic bone lesions on X-ray. This woman was treated, responded, and as you might imagine, over the years has relapsed, has responded, has relapsed on many occasions, but she is still living today and is active. Her disease is active now, but she is continuing to get around after 31 years, and there are many patients who are at 15 to 20 years. In the United States, we have the International Myeloma Foundation, and the IMF has a number of patient meetings or seminars each year. And one of the most valuable things for the patients attending this is to come and to see other patients with multiple myeloma, and they will meet people who have had the disease for 5, 10, 15, 20 plus years. And in many instances, when one meets the patient and his or her spouse, one cannot tell which one has myeloma and which one does not, which is a very positive thing and is very important, particularly for the newly diagnosed patient who is told that he or she has a very serious malignancy that is, quote, not curable.